It is such a privilege to have Dr. Blackett with us here today. He is an assistant professor of medicine in the Division of Digestive and Liver Diseases at Columbia University Irving Medical Center. Notice I didn't say that all on one breath. Even though my name is equally as long, I'm Mary Angela DeGrazia DiTucci, and I am a longtime patient with motility disorders. And along with that, I serve as a volunteer for the Association of Gastrointestinal Motility Disorders. And the Association of Gastrointestinal Motility Disorders, or AGMD, was incorporated in 1991. It's an international nonprofit organization. It serves as an information clearinghouse for digestive motility disorders. It also is an information clearinghouse for those in the medical, scientific, and nutritional communities. And of course, along with that, we are a form of educational support for those who are suffering from digestive motility disorders as well as for their families. This being Gastroparesis Awareness Month, it is really, as I was telling the doctor here, that there's been a swelling of awareness. For some reason, this year I think has been the tops, which is great. So with that being said, I just want to say that this program has been produced by AGMD, and it is made possible by a grant from Entera Medical and also a sponsorship of Evoke Pharma. Thank you very much all for being here. And Doctor, will you tell the audience a little bit more about yourself?
Yes, sure. Thank you. Thank you again for the introduction and the invitation to speak today. So I am a assistant professor of medicine at Columbia University in the Division of Digestive and Liver Diseases with a focus on neurogastroenterology and motility disorders. I did my residency and fellowship training here at Columbia, and I received my medical degree from Washington University in St. Louis. And then at Columbia also received a master's degree in patient-oriented research and epidemiology from the School of Public Health. And then did a advanced fellowship in neurogastroenterology and motility at the Mayo Clinic in Rochester, Minnesota. And then since then have been back at Columbia primarily as a clinician, seeing patients with motility disorders and general gastrointestinal disorders, including gastroparesis. And my clinical and research interests have mostly included, in addition to gastroparesis, other disorders of gut-brain interaction and pelvic floor dysfunction, fecal incontinence, and dyssynergic defecation. So I'll get started today. So today we'll be talking about a practical approach to drug therapy for gastroparesis, which is unfortunately a little bit of a depressing talk just because there are not so many effective drugs available for gastroparesis. But we'll talk about the ones that we do have and how there's really an unmet need for new medications and new treatments for gastroparesis. So I have no relevant disclosures. So the objectives of the talk today are to first briefly review the definition and underlying etiologies of gastroparesis, and then review the differences between classes of medications, prokinetics, antiemetics, and neuromodulators that we use for gastroparesis, and to go through the most common available individual medications, and then review a treatment algorithm for the medical management of gastroparesis. So I won't be talking very much about more advanced therapies like GPOM and gastric stimulators and feeding tubes. So we'll start with just a brief case study. So this is a typical sort of patient that we see in the gastroparesis clinic, a 26-year-old woman with type 1 diabetes that's been poorly controlled in the past and complicated by chronic kidney disease, peripheral neuropathy, coming in with 3 years of symptoms, including nausea and vomiting, bloating, fullness, discomfort after meals, constipation. And so she undergoes an endoscopy that shows food in the stomach despite fasting for over 12 hours. And she has biopsies that don't show any other causes of her symptoms, negative for celiac disease and H. pylori. And then she's referred for a gastric emptying study that shows delayed emptying with 32% retention after 4 hours, so moderate to severe delay. And her blood sugars are suboptimally controlled with a hemoglobin A1C of 9.2%, but her other labs are normal. And so she's diagnosed with gastroparesis, and she's referred to a registered dietitian and works with her medical team to improve her diabetes control, and her A1C improves, and she's following a gastroparesis diet under the advice of the dietitian, but her symptoms persist. So what are our options after optimizing diet and diabetes in terms of medical treatments before we consider more advanced therapies? So I'll start by just briefly reviewing the definitions of gastroparesis. So this is a syndrome of objectively delayed gastric emptying in the absence of any mechanical obstruction, and it's characterized by symptoms of nausea, vomiting, early satiety, belching, bloating, and can also present with upper abdominal pain. And there are a number of mechanisms that contribute to symptoms of gastroparesis. These can include abnormalities in stomach function and motility, like impaired gastric accommodation, dysrhythmias, gastric dysrhythmias, abnormal pyloric sphincter function, and decreased antral contractions. There can also be neurologic manifestation, pathophysiology contributing, like visceral hypersensitivity and abnormal central nervous system processing of signals coming from the GI tract. And over time, patients can also develop learned behavioral abnormalities that may develop as a response to chronic GI symptoms like food aversion and disordered eating as well, that can exacerbate and contribute to their symptoms. So the etiologies of gastroparesis can include diabetes, which in a recent epidemiological study based on a large US claims database was found to be the most common. In other studies, I've seen idiopathic gastroparesis reported to be the most common, but at least based on the most recent large studies that I've seen, diabetes is the most common, followed by post-surgical, which may develop after bariatric surgery, anti-reflux surgery like fundoplication, lung transplant, medication-induced, which is becoming more common with the widespread use of GLP-1 agonists like Ozempic and Mounjaro, opiate-induced gastroparesis, and then idiopathic gastroparesis is still quite common as well. Another less common or less definable etiologies include post-viral gastroparesis, and then also systemic diseases like amyloidosis, scleroderma, Parkinson's disease, and paraneoplastic gastroparesis, which refers to an underlying cancer that causes an altered immune response that can lead to abnormalities in gastric motility. And the prevalence, gastroparesis is still relatively rare. The overall prevalence estimates range from about 14 to 267 per 100,000 patients in the US. It's more common in women than in men, about 4 times more common in women. And it's far less common compared to functional dyspepsia, which has a prevalence of about 5 to 7% overall. And functional dyspepsia and gastroparesis typically present with essentially identical symptoms. They're only distinguished based on the fact that gastroparesis is characterized by objective delayed gastric emptying. But this is beyond the scope of this talk, but there is increasing awareness that functional dyspepsia and gastroparesis may occupy a spectrum of disease, and many patients can change phenotype over time. So patients who were originally diagnosed with functional dyspepsia and had normal gastric emptying may, when reassessed later, have delayed gastric emptying, and vice versa. Patients may have delayed gastric emptying on initial testing, and when retested may show normal gastric emptying. So there's not necessarily a hard line distinguishing these two disorders. And gastroparesis has a major impact on quality of life. About 2/3 of patients report having to reduce their daily activities. 11% report being disabled. And, patients are willing to undertake major risks in order to improve their symptoms. In a questionnaire study of 100 patients with gastroparesis, asking them what level of risk they'd be willing to accept with a hypothetical medication that cured their gastroparesis symptoms, the median overall risk was patients said that they would accept about a 13% risk of sudden death in order to cure their symptoms with a hypothetical medication. So these symptoms drastically affect patients' quality of life, and patients are willing to, in many cases with severe symptoms, use drugs that may have other risks in order to manage their symptoms. So this just goes to highlight the fact that there's a major unmet need for more treatments for gastroparesis. And so we talked a little bit about this already, but gastroparesis is defined by delayed gastric emptying, but the symptom severity does not always correlate with the degree of gastric emptying. Patients may have relatively mild symptoms, even with 50% retention at 4 hours, or may have very severe symptoms with only 15% retention at 4 hours. But common abnormalities that can be identified include impaired gastric accommodation, antral hypomotility, visceral hypersensitivity, pylorospasm or reduced pyloric distensibility of the pyloric sphincter, electrical dysrhythmias, and vagal nerve injury, which can occur after certain surgeries. And the gold standard for diagnosis is scintigraphy using a gastric emptying study. And this is a solid food, usually eggs-based meal. We evaluate the emptying measured over 4 hours. Oatmeal can be used for patients who have an egg allergy. Alternative ways of assessing gastric emptying include a wireless motility capsule or the spirulina breath test. Sometimes we see retained food on endoscopy. This can certainly be suggestive or raise our suspicion for gastroparesis, but is not diagnostic. Some patients with normal gastric emptying may still have food on endoscopy even after fasting, and patients with gastroparesis may have an empty stomach on endoscopy. And so these are the cutoffs for the normal values, the standard normal values for a 4-hour gastric emptying study. Usually we go by the 4-hour time. Over 10% retention at 4 hours is diagnostic of gastroparesis, or over 30% retention at 3 hours, or over 60% at 2 hours. But generally we like to see the full 4-hour test showing at least 10% retention at 4 hours. This is gastric scintigraphy showing significant radionucleotide retention in the stomach after 4 hours. So the general approach is to start with a history and physical examination and review for other symptoms that may suggest a systemic cause, like dysautonomia or Raynaud's phenomenon, which can suggest scleroderma, in which the fingers change color in response to cold. And to exclude mechanical obstruction or mucosal disease like ulcers with an endoscopy. And if that's all normal, then to pursue a scintigraphy to assess gastric motility. If there's a known underlying etiology like diabetes, that should be targeted. If the gastric emptying is normal, then that would suggest a disorder of gut-brain interaction or a functional dyspepsia. If they have delayed emptying and no known etiology, then getting basic laboratory studies like metabolic panel, complete blood count, evaluating their nutritional status by looking at protein, albumin levels, ruling out hypothyroidism can be useful. Gastroduodenal manometry is not widely available, but can be useful if it is available to distinguish between neuropathic and myopathic etiologies of gastroparesis, with myopathic etiologies including things like amyloidosis and scleroderma, neuropathic potentially including paraneoplastic syndromes or other causes of neuropathy. So the general principles of the treatment of gastroparesis are to target their predominant symptoms. So, we'll approach patients who have nausea and vomiting as their predominant symptoms, differently from patients who have primarily abdominal pain, and to target the underlying etiology wherever possible, especially if they have diabetes, for example, or a medication-induced gastroparesis like a opiate or GLP-1 agonist. And the goals of the treatment are first to improve patients' symptoms and quality of life, and then to prevent and reduce complications, which may include malnutrition or weight loss, reflux, esophagitis, or aspiration, pneumonias from vomiting, and then also to reduce healthcare utilization. Many patients with gastroparesis are in the emergency department or hospitalized very frequently, and treatment should hopefully also reduce their need for admissions. So the first line treatment is dietary, and this includes a small particle size, low fat, generally low fiber diet with frequent small meals 5 to 6 times per day. And when we say low fiber, we're primarily talking about things like salads, raw fruits and vegetables, nuts and seeds. Generally patients who have GI symptoms like constipation, we encourage a high fiber diet, but those kinds of foods can be hard for the stomach to break down and can delay gastric emptying. Fiber products that break down very easily, like well-cooked vegetables or fiber supplements, are usually better tolerated compared to eating like a salad or raw fruits or vegetables. And basically, all of these patients should be referred to a registered dietitian to guide their dietary modification plans. And then treating any specific underlying causes, like optimizing their glycemic control for diabetics and discontinuing opiates or GLP-1 agonists. For patients who use marijuana, we should try to exclude cannabinoid hyperemesis syndrome by recommending a trial of cannabis avoidance, ideally at least 3 months. For patients who've tried cannabis avoidance and don't feel like there's any benefit and feel like the use of cannabis is in fact helping them, I don't necessarily discourage it as long as they've given it a real try at stopping it and seeing whether eliminating cannabis helps their symptoms. And they should always rule out gastric outlet obstruction with an endoscopy. And so the general classes of medications that we use include prokinetics, which accelerate gastric emptying. These include metoclopramide, which can be oral or intranasal, erythromycin, domperidone, which is limited by availability, unfortunately, prucalopride, and pyridostigmine are all prokinetics. So starting with metoclopramide, this is the first line, oldest and only currently FDA-approved drug for gastroparesis in the US. And it's a dopamine receptor antagonist, as well as a 5-HT4 agonist and a weak 5-HT3 antagonist, but primarily is a dopamine receptor antagonist. And so it works to accelerate gastric emptying by enhancing antral motility and contractions. The typical dose is 5 to 10 milligrams, 3 to 4 times a day with meals and at bedtime, with the maximum dose being 10 milligrams 4 times a day. And this is also available as an intranasal spray. The intranasal spray provides faster absorption and can avoid problems where patients are having a flare of vomiting and can't keep any medications down. There is an open label study that suggested better symptom control than the tablets, particularly in women and diabetic gastroparesis patients. Side effects specific to the intranasal spray include dysgeusia or altered taste, and headache and fatigue. And then side effects of metoclopramide in general include extrapyramidal side effects like dystonia, basically muscle stiffening, and Parkinsonian side effects, abnormal gait, and tardive dyskinesia. The risk of tardive dyskinesia is low and is thought to be lower than previous estimates, less than 1% risk overall. We'll talk a little bit more about that. Anxiety and restlessness are also potential side effects of metoclopramide. Hyperprolactinemia, which can cause abnormal lactation, and QT prolongation, which can lead to potential ventricular arrhythmias. So generally, with metoclopramide, we encourage a drug holiday after 12 weeks of use. After 12 weeks, If we'll stop the medication for usually 1 to 2 weeks and see how their symptoms are. If their symptoms remain under control, we'll continue to monitor them off the medication. If their symptoms worsen again, then we can restart it, but continue to monitor them closely and try to periodically take them off the medication, usually every 3 months. So tardive dyskinesia, the risk is estimated at 0.1% per 1,000 patient years. So that means that out of 1,000 patients using metoclopramide for 1 year, one of them is expected to develop tardive dyskinesia. And the high-risk groups include elderly, especially elderly women, patients with diabetes, liver or kidney failure, or in particular patients who are on concomitant antipsychotic drug therapy, if they're on multiple dopamine antagonists, for example. This is, let's see if I can start this. This is just an example of what tardive dyskinesia may look like. Okay, so you'll see sort of abnormal facial movements in particular, sometimes abnormal tremors in the hands as well. It will usually resolve after discontinuation of the drug. But in patients who've been on metoclopramide for a long time, especially at high doses, and who don't stop the medication right away when the symptoms develop, it can become permanent. But it usually will resolve if patients stop the metoclopramide as soon as the symptoms appear. And the risk is still quite low, especially if we're careful to use the minimum dose needed to control symptoms and to institute a drug holiday every 12 weeks. Okay. Okay. So then we'll talk a little bit about domperidone. So this is a similar medication. It's also a dopamine receptor antagonist, but it does not readily cross the blood-brain barrier. So the risk of tardive dyskinesia is extremely low compared to metoclopramide. But it does have a significant risk of QT prolongation and ventricular tachycardias and arrhythmias. So monitoring with an EKG is required. It can also cause hyperprolactinemia and abnormal lactation. And it's not readily available in the US. It's only available under an FDA investigational drug application. And even that is looks like it's going to be very difficult to obtain in the future because the pharmacy that was supplying this is winding down their operations with domperidone. So it's probably going to be increasingly difficult to get domperidone in the US. The typical dose is 10 milligrams 3 times a day. There are observational studies suggesting improvement, although many patients have had to discontinue due to the risk of cardiac side effects. Although larger pharmacoepidemiological studies suggest the incidence of ventricular arrhythmias is only about 0.02%. But generally, for patients who are on domperidone, their EKGs should be monitored both at baseline and after starting, and then periodically while they're on it. And if their QTC on the EKG is ever over 450, then we would stop the medication. And erythromycin is another prokinetic. It's a macrolide antibiotic that binds to motilin receptors and accelerates gastric emptying. The typical dose of erythromycin is 100 to 250 milligrams 3 times a day. Main drawbacks of erythromycin are tachyphylaxis, meaning there's a diminishing response over time. So it may be quite effective for about a month and then less effective thereafter. But then if patients only use it for short periods during flares for 2 to 4 weeks and then stop it and then go back on it 3 months later, it may be effective again. Azithromycin is another macrolide antibiotic that may be used similarly. These medications also have a risk of QT prolongation, so should be monitored, especially if they're on multiple QT prolonging medications. IV erythromycin may be helpful for patients during flares while they're admitted. And then we also worry, because it is an antibiotic, about the risk of drug resistance and precipitating other infections like Clostridium difficile. So if patients have a history of recurrent C. diff, for example, this wouldn't be the best option for them. Prucalopride is a medication that's approved for chronic idiopathic constipation, It's a 5-HT4 or serotonin agonist, so it stimulates peristalsis in the GI tract through the release of acetylcholine from the myenteric plexus. And it's approved for chronic idiopathic constipation. So if a patient doesn't have constipation, it may be difficult to get insurance to cover it. But it certainly is an option for patients who have both gastroparesis and constipation, which is in my experience more often the case that they'll also have constipation. Other medications with a similar mechanism include cisapride and tegaserod, are also 5-HT4 agonists, but these are no longer available in the US. And volucitrag is also a 5-HT4 agonist that in clinical trials has been shown to accelerate gastric emptying, but the effect on symptom relief was much more modest and didn't meet clinical significance, and is just an investigational drug. It's not available yet for non-research use. But in small studies looking at prucalopride for gastroparesis, the gastroparesis cardinal symptom index did improve. There is a warning with prucalopride that there has been an association with worsening depression and suicidal ideation. These are very, very rare. I wouldn't discourage patients from using it because of that, but they should be aware of it, and if they experience any worsening mood or depression symptoms, should let us know and stop the medication. And then pyridostigmine is an acetylcholinesterase inhibitor that facilitates transmission of impulses across the neuromuscular junction. It works to improve the muscle contractility in the GI tract and can enhance GI motility. It's primarily originally used for myasthenia gravis. It strengthens muscle contractions in myasthenia gravis, which causes muscle weakness. It may be particularly helpful for patients who also have autonomic dysfunction, such as postural orthostatic tachycardia syndrome, in addition to gastroparesis, because it can increase blood pressure and lower the heart rate. So patients with POTS and gastroparesis who may have a rapid heart rate and low blood pressure and dizziness, it may work to improve both their autonomic symptoms and their delayed motility. It can also cause increased oral and respiratory secretions. So if patients have chronic dry mouth, that may be helpful, but if patients have excessive secretions, it may be bothersome. And there is a potential risk of bronchoconstriction as it causes smooth muscle contraction in the lungs as well. So patients who have significant asthma or COPD should avoid it or use very cautiously. And there aren't any randomized trials evaluating its use for gastroparesis, so the evidence is limited. So now we'll talk about antiemetics. These include things like ondansetron and granisetron, prochlorperazine, promethazine, cyproheptadine, aprepitant, scopolamine, and dronabinol. So the 5-HT3 receptor antagonists include ondansetron and granisetron. Ondansetron is available as an oral disintegrating tablet, 4 to 8 milligrams, can be used up to 3 times a day to relieve nausea. Granisetron is a similar mechanism, also available as a transdermal patch for patients who have trouble keeping pills down, although that can be difficult to get insurance to cover as it's much more expensive. And both of these medications also can prolong the QT interval. So again, when combining medications that have QT prolonging effects, their EKGs should be monitored. And these medications can also exacerbate constipation as well. Antihistamines include promethazine, which is also a weak dopamine antagonist, so should be used with caution if patients are also on metoclopramide, and cyproheptadine, which inhibits serotonin and has anticholinergic effects. So these, and also acts as a mild appetite stimulant. So these medications can cause fatigue, drowsiness, and dry mouth, but can be helpful as second-line agents after ondansetron or for treatment of nausea. Neurokinin receptor antagonists are one of the more potentially exciting upcoming classes of treatments for gastroparesis. The one that's commercially available now is aprepitant, and this works to block substance P and the brain regions that regulate nausea and vomiting. Aprepitant has shown benefit in an RCT over placebo in gastroparesis symptom score. The typical dose for aprepitant is 40 to 80 milligrams daily, can be used for up to 3 days in a row to interrupt a cycle of emesis. The main limitations are it's quite expensive, and frequently insurance will only cover it for patients who are on chemotherapy, or will only cover very limited quantities, like one pill per week, for example. So uh, I have patients who will use it as a sort of a rescue medication when their other medications are not working, but it's not something that we can usually get as a daily medication. Tradipitant is another medication in this class that has shown benefit over placebo in an RCT, but is not yet widely available. Scopolamine is another antiemetic. It's available as a patch that blocks acetylcholine and antagonizes serotonin and histamine. Places a patch replaced every 3 days behind the ear. Patients need to be careful not to avoid touching their eyes after handling the patch, as that can cause a blurred vision. And patients also should avoid it if they have narrow angle glaucoma. And this can also cause anticholinergic side effects, in particular, dry mouth, blurred vision, dizziness, and drowsiness. It's frequently used for motion sickness in patients who are on cruises. And then dronabinol is a synthetic cannabinoid. It activates CB1 and CB2 cannabinoid receptors. There are no major studies for gastroparesis at this point, but it is effective for relieving nausea in patients undergoing chemotherapy, and acts as an appetite stimulant. But there is a concern that cannabinoids and marijuana in general can delay gastric emptying. So, there's sort of varying reports and controversy about whether these medicines can be helpful or harmful for gastroparesis. They can dramatically improve nausea and vomiting in some patients, but there are patients whose nausea and vomiting may be directly related to use of cannabis. And so it can be difficult to figure out which patients are helped and which patients are hindered by it, but it can be a useful medication to try when other medications have failed. So now we'll talk a little bit about the neuromodulator class of medications. So these medications act both centrally and peripherally to reduce visceral pain in patients with functional dyspepsia, and have been studied as well for gastroparesis. We can choose a specific neuromodulator based on the patient's symptoms, and it can also be helpful for treating coexisting psychiatric comorbidities. So patients who also have anxiety, depression, which may be triggered by their GI symptoms or may be contributing to their GI symptoms, neuromodulators can target some of those disorders as well. And they reduce visceral hypersensitivity, and in some cases can modify GI motility, primarily for patients who have diarrhea. They can slow down motility, which is useful for patients with IBS with diarrhea, less desirable in patients with gastroparesis, and can also improve the central downregulation of visceral signals coming from the GI tract. So mirtazapine is a medication that I will often use for gastroparesis patients. It's a tetracyclic antidepressant with noradrenergic and serotonergic activity, and also has histamine antagonism. And in a small study, it did improve refractory nausea and vomiting in 30 gastroparesis patients. And there are other studies looking at it for functional dyspepsia, where it improved weight loss and dyspepsia, and especially early satiety, so fullness after eating. We'll typically start at a dose of 7.5 milligrams at bedtime and increase it up to 30 milligrams if needed and tolerated. The main things that we watch for are drowsiness and weight gain, which is usually, the weight gain is usually a desirable side effect in gastroparesis patients. But if you have a gastroparesis patient who's overweight and doesn't want to gain weight, then that it should be considered. But these medications can improve appetite and relieve nausea and fullness. There are some patients who report that they do have a good appetite, they just have nausea and pain when they eat. In those cases, it may not be the best choice, because then stimulating their appetite, but them still being unable to eat may make them feel worse overall. But in patients who just report low appetite, and especially if they're underweight or have trouble gaining weight, mirtazapine can be a helpful adjunctive treatment option. And tricyclic antidepressants are frequently used for irritable bowel syndrome and functional dyspepsia. They include nortriptyline, amitriptyline, and imipramine, and they improve abdominal pain and functional dyspepsia, in particular amitriptyline for functional dyspepsia and IBS. They don't significantly slow gastric emptying, although they can exacerbate constipation. But unfortunately, the only placebo-controlled trial evaluating nortriptyline for gastroparesis was negative. There was no improvement over placebo. And then SNRIs include duloxetine and venlafaxine. These are frequently used to treat patients with diabetic neuropathy. And from similar logic, they can be helpful for patients who have visceral pain in gastroparesis, but they have not been specifically studied for gastroparesis. So in particular, patients who have diabetic neuropathy and may have abdominal pain or other types of pain, they can be helpful, but their efficacy for gastroparesis is uncertain. So this is an overall study, meta-analysis looking at 25 different randomized controlled trials for drugs treating gastroparesis over the last 40 years. And you can see that of all the drugs that they looked at, essentially none of them were really significantly more effective than placebo. So the medications that lie to the left of the line here favor the drug. The medications that lie, if the dot lies to the right of the line here, they favor the placebo. If they lie right on the line, then really no difference between drug and placebo. And the horizontal lines represent the confidence intervals. So you can see that for most of these, there was really no improvement, for example, in prucalopride over placebo for gastroparesis, and similarly for nortriptyline. For nasal metoclopramide, there was some trend towards benefit over placebo, but the confidence intervals crossed over, so it wasn't a significant difference. And similarly for tradipitant, this was closer, but the confidence interval still crossed over with placebo. The two medications that were the most effective were clebapride, which is a dopamine antagonist, and domperidone. But the evidence for clebapride is based on a single randomized controlled trial of less than 100 patients, and this drug is also not available in the USA. There is some evidence that the risk of tardive dyskinesia and other extrapyramidal side effects is higher compared to metoclopramide. And then domperidone was just barely more effective than placebo, but again is not widely available in the US outside of the investigational drug application, which is increasingly difficult to source. And then in terms of drug, when we look at specific drug classes, lumping together all the oral dopamine antagonists, which include metoclopramide, domperidone, clebapride, or the tachykinin 1 antagonist, which includes aprepitant and tradipitant, those were more effective as classes compared to placebo. So there may be, over time, we may see other drugs in those classes that are more specifically more effective, or larger studies looking at them. Those are the best drugs that we have available right now, but unfortunately, the evidence is not outstanding for either. So I'll talk a little bit about other treatment approaches besides the prokinetics and neuromodulators. Opioid analgesics should not be used for gastroparesis patients in general if they can be avoided, because they delay gastric emptying, and there's a risk of narcotic bowel syndrome and a risk of addiction or dependence. So in general, these should be avoided for chronic abdominal pain. In patients who need to be on them, peripherally acting opioid antagonists or PEMORAs like methyl naltrexone and naldemidine have been used for opiate-induced constipation, and the use of them in patients with opiate-induced gastroparesis, it has been shown to reduce gastric residual volume, so seems to improve gastric emptying, but there are not any studies looking at symptom improvement for patients with opiate-induced gastroparesis. Many patients with gastroparesis also have coexisting constipation, and that should be addressed. In many cases, the constipation exacerbates and contributes to their upper GI symptoms. Laxatives may relieve the nausea and bloating if patients are very constipated. Prucalopride is a good option for patients who have both because it does accelerate gastric emptying, even though it has not been shown by itself to improve overall gastroparesis symptoms. If they have constipation and gastroparesis, there's a possibility it may be more effective. This is just an overview of different laxatives available and their mechanisms. Polyethylene glycol is an osmotic laxative that is the main ingredient in most bowel preparations for colonoscopy. It creates an osmotic gradient to pull water and electrolytes into the colon to make stools softer, easier to pass, but it can be associated with more bloating symptoms. Bisacodyl and senna are stimulant laxatives that can be helpful, especially as rescue medications, but can be associated with more urgency, diarrhea, cramping. Plecanatide and linaclotide are guanylate cyclase agonists used for IBS with constipation. Prucalopride we talked about. Tegaserot, unfortunately, is no longer available. Tenapanor is another medication used for irritable bowel syndrome. It's a sodium hydrogen exchanger that also promotes water and fluid secretion into the colon. And then lastly, lubiprostone is another secretagogue medication similar to plecanatide or linaclotide, but carries an increased risk of nausea. So generally, I would avoid that in patients with gastroparesis and IBS and constipation. Acid suppression can be helpful for some patients because many patients with gastroparesis also have acid reflux. Proton pump inhibitors like omeprazole, pantoprazole may mildly delay gastric emptying of solids by impairing peptic hydrolysis. There are studies suggesting that the gastric emptying half time may increase by about 15 to 30 minutes at the usual PPI doses. So not a dramatic delay increase in gastric emptying, but it can slightly slow down stomach emptying. But because many patients with gastroparesis also have severe reflux symptoms, and the PPIs are very effective at treating that, I wouldn't avoid PPIs in patients who have both gastroparesis and GERD. But if a patient really doesn't have GERD symptoms, should try to avoid PPIs. And then I'm not going to talk really about the non-drug therapies, but just to mention these as potential options when, if medications are not controlling symptoms, GPOM, botulinum toxin injection to the pylorus or pyloromyotomy, a gastric stimulator, and then for patients with really refractory symptoms, sometimes nutritional support like a GJ or a J2 or even parenteral or IV nutrition may be necessary. And then novel therapies include things like IVIG for patients with underlying that's IV immunoglobulin infusions for patients with autoimmune or neuromuscular disorders. Acupuncture, there are some small studies evaluating gut-directed hypnotherapy and relomorelin, which is a ghrelin receptor agonist. So IVIG, there is a subset of patients with refractory gastroparesis with underlying autoimmune-mediated neuromuscular dysfunction, and there are some small retrospective studies that show symptom improvement for these patients with administration of IVIG, but the evidence is overall limited. Acupuncture is thought to modulate GI motility and alleviate symptoms by working on autonomic nervous system and neurohormonal pathways. It may enhance the vagal nerve activity and regulate gastric slow waves and alter the secretion of GI hormones. There are very small studies that have suggested short-term benefit, but the quality of the evidence is quite low. So I don't discourage patients from trying it if their symptoms are really refractory, but we don't have really significant evidence for its use in gastroparesis. So this is just an approach, a treatment algorithm for refractory gastroparesis patients. So generally, we want to consider what their predominant symptom is, whether it's nausea and vomiting or abdominal pain or discomfort. and you want to rule out other potential causes, celiac artery compression syndrome or MALS, median arcuate ligament syndrome, superior mesenteric artery syndrome, cannabinoid hyperemesis syndrome or cyclic vomiting syndrome, intestinal pseudoobstruction, narcotic bowel rumination syndrome. So once we've evaluated, considered other etiologies and have diagnosed them with gastroparesis, if nausea and vomiting are the predominant syndrome, we start with dietary modifications following a strict gastroparesis diet and using antiemetic agents, in particular ondansetron. As symptoms become more significant, then we may introduce prokinetic agents like metoclopramide, as well as things like cognitive behavioral therapy and hypnotherapy as adjunctive treatments. And for severe symptoms, that's when we start to consider things like enteral nutrition, GPOM, gastric stimulators. For patients who have predominantly abdominal pain, then neuromodulators may be a little bit more effective. We should make sure that they're not using opiate medications or GLP-1 agonists. Similarly, CBT and hypnotherapy may also be effective for this group. So I think overall it's important to take a multidisciplinary approach for patients with refractory gastroparesis, starting with a dietitian, because dietary modification is the mainstay of therapy for most patients with gastroparesis. And then as a gastroenterologist, my role is mainly to try and titrate different medications, the antiemetics, neuromodulators, and prokinetics while monitoring closely for any side effects. When the symptoms become more refractory to medical management, then it is important to have surgery on the team who can consider them for more invasive therapies like GPOMs, pyloromyotomies, gastric stimulators, jejunal feeding tubes. We try to avoid those as much as possible, but there are patients for whom medical therapies are not effective. And then having an endocrinologist to manage diabetic gastroparesis is also important, and having someone who can, a psychiatrist or psychologist who can help provide gut-directed cognitive behavioral therapy or hypnotherapy and treat coexisting anxiety and depression is also important because of the significant effect of their symptoms on these patients' quality of life. Anxiety, depression are very common. So just finishing up with the case study that we introduced initially. So this was a 26-year-old woman with type 1 diabetes, presenting with nausea, vomiting, constipation, abdominal pain, who was diagnosed with gastroparesis after an endoscopy and gastric emptying study, and tried dietary modifications and improving her glucose control, but has had persistent symptoms. So what medical therapies would we consider next? So metoclopramide is, again, the only FDA-approved medication for gastroparesis. This can be an oral tablet or a nasal spray. Its use should be limited to 12 weeks, followed by a drug holiday. So that is generally the first-line prokinetic medication that we'll use. Prucalopride may, in this case, be also a good option because she reports significant constipation. Especially if she has concerns about long-term use of metoclopramide, prucalopride may be a better option to try. Mirtazapine can be helpful for patients who have predominantly nausea, fullness, low appetite, and early satiety. And ondansetron is also a very helpful medication to take as needed for nausea as well. So that would be the initial approach in my practice for this type of patient. So again, excluding other causes like mechanical obstruction, we confirm the diagnosis with a gastric emptying study, typically a 4-hour solid gastric emptying study, but wireless motility capsule or a spirulina breath test are potential alternatives. We start with dietary modifications, a small particle, low-fat diet, and then consider pharmacologic treatments, in particular prokinetics, antiemetics, and neuromodulators. And then for patients who have truly refractory symptoms, then we start to consider non-pharmacological treatments like the GPOM stimulator and feeding tubes if necessary. So I will wrap up here, and if there are any questions.
Pam,
I have a question.
Mhm.
One of my questions that I had put in earlier was already answered. What happens when medications do not work anymore? But my question is, I have very severe gastroparesis, and I had it with colon inertia. So after colectomies, colectomy reversals, small bowel resectionings, I now have short bowel also. I have had a JG in the past, but I'm on TPN now. But medication is not helping my symptoms at all. And I'm wondering whether putting in a G tube for emptying of the stomach or the Intera, what are the pros and risks of those options, and what might be a better option?
Mhm.
That, yeah.
Yeah, yeah. For patients who have really complex surgical histories, the treatment has to be much more individualized. Most of the patients in the studies um, have not had, as much altered anatomy. So I think that you were asking whether a venting G tube may help to relieve symptoms, and you said you've tried J tube feeds and they were not effective, or you didn't
Well,
tolerate
I
them.
did have a JG for a while, but after they
Hmm.
reversed my colectomy, I think
Hmm.
my gastroparesis kind of like was not that bad. And I made the decision to pull the JG tube at that
Yeah,
time.
yeah,
Um, but then after the short bowel and all and severe nutritional deficiencies, I'm on TPN now. But
yeah,
I'm not sure whether maybe to do a G tube for entering or Entera.
yeah, yeah. So I think it depends a little bit on what your predominant symptoms are. The G tube, is only going to really help with venting the stomach. It doesn't sound like it would be useful for feeding. I do have patients who find it very effective at preventing vomiting if they're able to vent the stomach, but it doesn't provide any nutritional support. So I don't think it would be a pathway to getting you off TPN. If it may improve your quality of life and lead to less frequent hospitalizations or admissions if you're having frequent vomiting in order to be able to vent your stomach periodically. Um, the stimulator is also effective primarily for nausea and vomiting. So if those are the predominant symptoms, that is certainly could be an option. Um, and there is a potentially if the symptoms improve enough, then there's a possibility that you could be able to come off TPN, which would be the goal in most cases because of the risks of IV nutrition. I think it's hard to, without reviewing the whole case, give a firm recommendation about whether a venting tube or a stimulator is a better option in your case. But I would say that overall, the venting tube is probably only helpful if you're having really frequent nausea and vomiting that's leading you into the hospital, but I don't see it really getting you off TPN long term.
Thank you.
Yeah.
anyone else have a question? I know some people had submitted questions, but your presentation covered them all, which is great. Are you finding that in your practice, there are a lot of patients who have gastroparesis, but they also have other diseases as well? Or are you finding most of them either diabetic or idiopathic in your particular
Yeah.
practice?
So I would say the majority are still diabetic or idiopathic, but at our hospital we do see a lot of patients with post-surgical gastroparesis. I think mainly because there's a large lung transplant center here, and it's relatively common for the post-lung transplant patients to develop gastroparesis, and they often have a host of comorbidities underlying interstitial lung disease and connective tissue diseases, scleroderma and things like that, that can also contribute to the gastroparesis. So that's quite common at our hospital, but I think is less representative about the overall population of gastroparesis patients. We see a lot of patients with Ehlers-Danlos and other connective tissue diseases that seem to predispose to gastroparesis, but unfortunately, we don't really have specific treatments to address that beyond what we've used for idiopathic gastroparesis.
I see. And tell me, and I know we discussed this before, but the majority of patients who have gastroparesis and other GI issues seem to be women. Do you have a theory on that? Is it because men are reluctant to go to a doctor more so than women, or is it just because this patient population, it just affects it more for no known reason?
Yeah, that's a good question. I mean, we see that not only in gastroparesis, where women are about 4 times more likely, the prevalence is about 4 times higher, but in other many other disorders of motility disorders like irritable bowel syndrome and functional dyspepsia and pelvic floor dysfunction, women are much more frequently affected. Part of that certainly may be that women are more likely to seek care, but I think that there are some underlying differences that make women more likely to have developed these disorders. I don't think that we have a great understanding yet, and I think more research is needed to identify the precise reason that women are more frequently affected. But I don't think it's purely just due to women being more likely to seek care. I think that may play a small role, but I think overall women are more commonly affected than men.
And I would imagine hormones play a huge part with the GI tract as well.
For many patients it can,
Yeah, excellent. Well, Dr. Blackett, I can't thank you enough again for all your time and an excellent presentation, very clear, very understandable, and very direct. So we really appreciate all that you've done for us today. And I always close these programs the same, that you are all my heroes, including you, doctor, that you patients are the ones who suffer 24 hours a day, and you are quiet because the world may not know about what you're going through. But certainly I have an idea. We're just living the life here. Know that you may feel alone, but you're not alone, because my heart remains with you every single day, as do my prayers. And of course, I think of you, and I try to think of other ways that we can help where medicine doesn't seem to be helping, or in conjunction with where it does help. Thank you so much again, and we really appreciate all you did today, and may God bless you all. Thanks so much again. Take care. Bye-bye.
Yeah. Thank you very much. All right. Take care.